Hello, this is Dr. Philip May. I'll be speaking with you today on the introduction to the evaluation and treatment of destructive behaviors in persons with developmental disabilities, the value of longitudinal graphic analysis. Longitudinal graphic analysis is an ongoing process of graphic correlation of the frequency of a specific symptom with the dose of a specific treatment designed to affect the frequency and or severity of that symptom. And on this slide you can see an Excel graph which correlates a symptom with a dose, and the symptom is the blue line, and in this case self-injurious behavior, and the dose is Zyprexa with the red line, and there's a time period from January 2008 through May 2009. So year and a half worth of information there, and the graph is called a treatment efficacy graph. So the process is simply to define a symptom, pick a treatment and try it out, and then document what happens, what the effect of that treatment is on the frequency of the symptom. And that's what we're going to be talking about. Now, a couple of factors to consider in the analysis of disruptive or maladaptive behavior, and that is frequency and severity. And frequency can be defined, and this is an arbitrary definition, as either high, moderate, or low. If there's an episode that occurs once per day, that would be about 30 times per month. That would be considered high frequency. Severity is often defined as high, moderate, or mild, high being if there's injury to a person, others, or property. In other words, there's actually destructive outcomes to the behavior. If it's mild, there's no significant injury or disruption. So first you have to define what you're talking about, whether it's self-injurious behavior or aggressive behavior or destructive behavior, whether it's property destruction, and decide whether you're going to only count high severity or you're going to count all. Or you can then, once you decide what you're going to be counting, the staff has to be clear, or the families, if they're going to be counting the incidence of behavior, and then you get started. Now here's an overall view of the longitudinal graphic analysis method, and generally it consists of 5 steps. The first step is you carefully define a target behavior to be counted, and for example self-injurious behavior that we were talking about before, in terms of whether you're going to count severe cases only, or mild cases, or all cases, and exactly what is the behavior. It has to be a very carefully thought out definition of that target behavior that's going to be counted, and whoever's going to be counting it has to be trained in that, so there's an agreement on what an incident it is. The second step is to establish a baseline frequency. Now all behaviors fluctuate. Some months it'll be higher than others. Behaviors tend to go up and down. Behaviors are very complex phenomena, and there are probably many internal and external factors which influence it. Mood, self-injurious behavior may be very frequent one month, and the next month not so bad. And this could be because Maybe a certain staff person is either there or not there, whether there's been a group change, whether a person has some kind of intercurrent illness, or there are other people in the group home that are being disruptive. So there's so many complicated issues that may impact on the frequency of that behavior. So what you want to have is a general feel for, in general, does this person have 100 times a month or 10 times per month frequency in general? So it's important to establish a baseline frequency so you have a feel for how many times per month this behavior occurs. And it's good to have at least a 3-month baseline. If there's an emergency behavior, then of course you have to change your plan. But if it's possible, a longer baseline period is very helpful. The third step is to establish a working diagnosis. For example, if there's self-injurious behavior, what is causing this? Is it a manifestation of a psychiatric disorder, or is it an environmental problem, or is there a medical problem? So you have to try to figure out why this is happening. And then the fourth step is to begin treatment, or have an intervention based on the diagnosis. For example, if the behavior is very bizarre and the person may seem to be hearing voices or having some kind of hallucinations, you may diagnose atypical psychosis, in which case a neuroleptic medication would be an appropriate intervention, for that. On the other hand, the behavior may be related to an environmental issue, and you may have to consider that. Then in step 5, you establish the outcome. You continue to determine the frequencies and adjust the treatment based on the outcome. So if the Zyprexa correlates with a reduction in frequency and or severity of the symptoms of self-injurious behavior, then you say, well, you're on the right track. And of course, you always have to consider side effects. There are side effects to all treatments, medical and non-medical. So even a behavior modification program has side effects. So if restraint is used as part of the behavior modification program or redirection, you have to look at all the downside of all interventions need to be considered. Now here's a case example. This is a 25-year-old man with a severe intellectual disability due to birth injury. He began demonstrating impulsive destructive behaviors during adolescence. There's no significant motor dysfunction, there's no cerebral palsy, no history of seizures. At the current time, he is demonstrating face slapping and wrist biting when he becomes frustrated. At times, he demonstrates these behaviors for no obvious reasons. His parents are very concerned because the behaviors seem to be getting worse. He lives at home with 2 normal siblings. So what are we going to do? Okay, it was decided to try Zyprexa in this individual after a baseline period from January to June. So that's about 6 months or 7 months of a baseline period. The family collected the frequency of the SIB. They decided they would count all what they felt were significant incidents of self-injurious behavior at home, and they recorded the episodes. They brought them into the doctor. And you can see in January of 2008, there were 30 incidents a month. In February, there were 20, and then back up to 35. So you can see that how important the baseline period is, because if you had immediately started Zyprexa before the baseline, say in January of 2008, and they came back a month later and the frequency was down, you would say, oh, look, the Zyprexa is working. But of course, the next month it goes back up again. So you have to know how much, some people call it background noise, or variation of baseline behavior, how much variation there is. The more variation in the baseline, the longer you need to get a feel for what the baseline frequency is. But in August of 2008, the Zyprexa was started at 5 milligrams per day, then increased to 10, then to 15, up to 20 milligrams per day. And you can see the behavior kind of came down. It looks like the Zyprexa is working. And of course, you always have to worry about side effects. There's a lot of talk about Zyprexa and metabolic syndrome, diabetes, hyperlipidemia. So some people monitor hemoglobin A1C. So anyhow, but you always have to consider side effects. There's the motor side effects you have to worry about. But nonetheless, at least the symptom appears to be efficacious, and so far there are no significant side effects. So it was planned to continue the Zyprexa, but you see the behavior is not completely eliminated. There's still 5 to 7 times per month he's still having self-injurious behavior. Much improved, but not perfect. So what's the next step? In a situation like that, the family would like to see him have no incidence of self-injurious behavior. So on the next slide, we're going to continue that. This one ends at May 2009, and we will start in June 2009 on the next slide. Okay, we are at June 2009, and you can see in the red rectangles the Zyprexa is still at 20 milligrams per day, and it was kept at 20 milligrams per day through November 10th. So what did we do? You can see the behavior is going along initially at 4 to 7 or 8 times per month, and it was decided to add Depakote to try to completely eliminate the self-injurious behavior. And he was kept on Depakote on this graph from September 2009 through November 2010. And you can see that there was no significant reduction in the frequency of the behavior. So we would say that Depakote does not seem to be adding any additional benefit. And ideally, at some point, 6 months go by, a year, the Depakote should be tapered if it's not showing any benefit. Unfortunately, that doesn't happen very often. What usually happens is another drug is added, and on the next slide we're going to show you what happens when we add another drug. We continue the Zyprexa and the Depakote, and on the next slide we're going to add another class of psychotropic medication. Okay, we chose Paxil. You can see again, you get oriented there. You see the Zyprexa now is still at 20, and the Depakote is still at 1,500 milligrams per day. And in March 2011, Paxil was added, and the Paxil was increased up to 30 milligrams per day. and kept on that dose through October 2011. And it looks like the behavior frequency in the blue line, the self-injurious behavior, actually increased after the Paxil was started. Now, this increase could have been due to the Paxil, or it could have been due to some other factors. Maybe there was an environmental change, different staff people. Maybe he started a job and wasn't getting along, well at work. But if you rule out all those environmental factors, it could be that the Paxil was playing a role in worsening the behavior. And it's something that we see quite frequently. The antidepressants, they kind of activate the person and kind of boost the brain, and sometimes it causes more irritability. So ideally, I think we've shown that looking back from the beginning, that the Zyprexa appeared to have some benefit. The Depakote had no effect at all, and the Paxil was making him worse. But you can't come to that conclusion. Those conclusions are different conclusions based on that graph alone. You need a longitudinal graph. You need the other previous graphs 1 and 2. To know that. And unfortunately, the prescriber is not always given complete information, longitudinal information, and the information is based on something very incomplete. And if you don't have that history, that drug history, then looking at this slide, you look at the Zyprexa and the Depakote, you can't tell whether they're efficacious or not. You need the previous data. Otherwise, you'd have to taper those. If you taper the Zyprexa, then his behavior would probably get worse. We know that because it was efficacious before, and you would subject the person to worse behavior and worse self-injury. So just to quickly review the 5 steps of LGA. You carefully define the target behavior to be counted. Number 2, you establish the baseline frequency. 3, you establish a working diagnosis. 4, you begin treatment. And 5, you establish the outcome. The value of longitudinal graphic analysis. It provides longitudinal record of specific problematic target behaviors demonstrated by an individual. It provides a longitudinal record of specific interventions, medications, behavior programs, whatever you use to alter the target behavior, and it provides evidence for efficacy or lack thereof of the various attempted interventions. So it's a documentation, a recorded document that is useful to clinicians, and it's a quick way to see what has worked and what has not worked in the past when it's produced. Okay, just to supplement what I've been telling you, there's a very good book by a professor at Harvard, Edwin Michelson, a professor of psychiatry. I would recommend this book to you. It's called The Rational Use of Psychotropic Medication for Individuals with Intellectual Disabilities. And I'm going just to take a couple of quotes from that book. Okay, one regarding the failure to determine efficacy. Dr. Michelson says, in his experience, a primary contributor to the use of multiple psychopharmacological agents in individuals with intellectual disability is the failure to empirically determine the efficacy for existing medication before adding additional agents. And I think the case example I gave you supports that concept. And he also says that if a clear, concise visual presentation of the behavioral data is not available, the prescriber may default to an acceptance of the subjective opinion of whichever staff member happens to accompany the patient on that day. That could be staff or family. So if you don't have the data and you're you're basing your treatment decisions based on impression, that can be very unreliable. So that's been my personal experience as well. And Dr. Mickelson's take-home message, I will just focus your attention on the egg on the right-hand side. It says, provide the prescriber with information that will allow him or her to make database decisions. And I think that's the best way to practice this type of medical treatment. So, final conclusion, careful and complete evaluation and treatment of problematic behavior encountered in adults with developmental disabilities can lead to a significant improvement in quality of life for this special needs patient population. Thank you very much for listening, and stay tuned for other talks on this topic. Bye-bye.